Thank you. Our next presenter is Dr. Robert Mutter of the Mayo Clinic, presenting a Phase 2 randomized trial of conventional versus hypofractionated post-mastectomy proton radiotherapy.
Thank you. On behalf of collaborators at Mayo Clinic Arizona and Mayo Clinic Rochester, Minnesota, it's my pleasure to present to you results from our randomized Phase 2 trial. Post-mastectomy radiotherapy, or PMRT, typically involves radiation therapy to the reconstructed or non-reconstructed chest wall, as well as the regional lymphatics, and has been shown to reduce both local, regional, and distant relapse and improve overall survival in lymph node positive and locally advanced breast cancers. However, the benefits of PMRT are partially offset by the effects of heart, lung, and other soft tissue exposure outside of the target volume, as well as increased rates of reconstruction complications. Radiation therapy planning involves a trade-off between target coverage and normal tissue sparing. And on the left, you can see despite a deep inspiratory breath hold, which moves the heart away from the chest wall and compromises in the internal mammary nodal coverage, there's still some high dose over the left anterior descending coronary artery. With IMRT, there's improved conformality of the high dose region to the target, but this comes at the cost of a low-dose bath. Proton therapy takes advantage of distinct physical properties of protons to enable improved normal tissue sparing, and here without any compromises in target coverage. And there's strong rationale to continuously limit exposure to non-target tissues because, for example, a linear relationship between cardiac dose and major coronary events has been shown, and current models suggest that there's no threshold below which there's an absence of risk. A significant dose effect relationship has also been shown for secondary cancers such as lung cancer, and compromises in target coverage may also increase relapse. There are 2 photon versus proton randomized controlled trials ongoing, but the primary endpoint results of 10-year major coronary event rate will not be available until at least 2034. And in the interim, protons are increasingly used in practice and permitted in some cooperative group local regional clinical trials. And this is based on retrospective reports and prospective single-arm proton therapy studies of PMRT or breast plus nodal irradiation. And the collective summary of this work is that there was excellent normal tissue sparing, safety and feasibility with low rates of relapse. But I'll note that all of these studies use conventional fractionation over 5 to 6 weeks. Meanwhile, in the photon literature, there's been a move towards hypofractionation. Hypofractionated photon whole breast radiation is now the standard of care based on randomized controlled trials demonstrating non-inferiority in terms of disease relapse, but also similar or reduced rates of complications. Hypofractionated photon PMRT also appears safe and effective in patients without reconstruction. And for patients with reconstruction, clinical trials are ongoing and the results are awaited. Hypofractionation for proton therapy is potentially attractive because protons requires increased capital investment, and therefore shortening the treatment course could potentially reduce cost and improve access to this normal tissue sparing technology. At the same time, protons have distinct physical properties, namely a higher linear energy transfer, and this may also result in distinct biological effects, and therefore it's uncertain whether it's appropriate to extrapolate from photon hypofractionated studies alone. Because the optimal dose and fractionation for proton PMRT is not known, we designed this randomized Phase 2 trial for patients with breast cancer and indications for PMRT. We stratified patients based on whether they had reconstruction or not at the time of radiotherapy, and they were randomized to either conventional fractionation, 50 gray in 25 fractions, or hypofractionation, 40 gray in 15 fractions with a relative biological effectiveness, or RBE, of 1.1. Inclusion criteria included age 18 years or greater, breast cancer resected by mastectomy with or without immediate reconstruction and indications for PMRT. Axillary staging was required, and radiation had to begin within 12 months of the last surgery or last chemotherapy. We excluded patients with persistent positive margins, inflammatory breast cancer, recurrent breast cancer, boosts to the chest wall, or prior receipt of ipsilateral radiation. Our primary objective was to determine whether the 24-month complication rate of 15-fraction proton PMRT was acceptable relative to 25 fractions. And we defined complication as either grade 3 or greater late adverse event in any patient, or unplanned surgical intervention in patients who underwent mastectomy with reconstruction. We used the approach of Friedland and colleagues, which allows sequential testing of non-inferiority and superiority in the same trial. We assumed a 24-month complication rate of 10% in the control arm, and that a 5% decrease in the experimental arm may reasonably be expected. And this was based on results of the START-B whole breast radiotherapy trial, in which 15 fractions was associated with less late adverse events than 25 fractions. With a non-inferiority margin of 10%, the study had 80% power and a one-sided type 1 error rate of 5% under the alternative hypothesis that the complication rate in the experimental arm is 5% less than in the control arm. We randomized 88 patients. There were 6 cancellations, 3 in each arm, including 3 patients that were denied insurance coverage for proton therapy and participation in the study. And that left 41 patients in each arm that completed the protocol treatment. Our techniques for proton PMRT have previously been described. Briefly, we utilized a newer technology called multi-field optimized pencil beam scanning, and this technique is distinct from prior reports of aperture and compensator-based proton therapy, in part because it does allow some skin sparing, as shown here, for example, at the nipple areolar complex in a patient that underwent nipple-sparing mastectomy. For dosimetric outcomes, briefly, the heart mean dose was 0.54 gray with 25 fractions, and 0.49 gray for 15 fractions, and the ipsilateral lung volume receiving 20 gray or more was 13.9% and 8.6% respectively. As you can see, the patients were well balanced with regard to age, laterality, clinical T and N stage, and estrogen receptor positivity, axillary surgery, mastectomy type, chemotherapy. The majority of patients did undergo immediate breast reconstruction, and this was predominantly with implant-based reconstruction, and specifically 2-stage expander to implant reconstruction with the expander in place at the time of radiotherapy. For the primary endpoint of 24-month complication rate, there were 6 complications with 25 fractions and 8 complications with 15 fractions, and the same number of complications at 36 months as well. This was not significantly different, with a p-value of 0.26. However, because the upper bound of the 95% confidence interval for the absolute difference exceeded 10%, the non-inferiority could not be claimed, and therefore a test for superiority of hypofractionation was not performed. In terms of complications, there were 5 patients in the conventional arm that had unplanned surgical intervention for contracture, and 1 patient had an infectious complication. And with hypofractionation, there were 8 patients that had infectious complications. On univariate analysis, only immediate breast reconstruction was significantly associated with complications. In terms of grade 2 or greater acute adverse events or late adverse events, in general, these were similar between the 2 arms, except there were less grade 2 or greater acute radiation dermatitis events, and there was a trend towards increased late breast infection adverse events with 15 fractions. In terms of progression events, there were 7 total, 4 with 25 fractions, 3 with 15 fractions, and just 1 local recurrence. This occurred simultaneous with a regional and a distant relapse in 1 patient with 15 fractions. Again, with a median follow-up of 39 months, the 36-month progression-free survival was 89% with conventional fractionation, 92% with hypofractionation. In conclusion, pencil beam scanning proton therapy provided excellent local regional control and exquisite normal tissue sparing. The implant-based reconstruction complication rates appear comparable to the photon literature. There was no significant difference in the overall complication rates between the two arms, but non-inferiority of 15 fractions could not be established, and this may be due to limitations in the sample size. Results of larger photon hypofractionated PMRT trials are awaited, and additional investigation into the optimal dose and fractionation of proton PMRT is also warranted, with hypofractionation appearing worthy of further study. I would like to recognize my co-authors and other contributors to our study, and especially thank and honor the patients that participated. Thank you.
Okay, we'll start with an online question. How do doses delivered through breath hold technique compare with those delivered through proton therapy?
Thank you. As I showed in one of the first slides, our standard at our institution is to employ a deep inspiratory breath hold for patients that receive photon therapy. Typically, this does result in a reduction in dose to the heart as well as to the lungs, but still with proton therapy you're able to achieve superior normal tissue sparing. Because we didn't have a photon arm here for comparison, I don't have comparative data, but I can tell you that roughly there's still a 3 to 4-fold relative reduction in general in our practice with heart dose, for example.
And in person, microphone 3.
Yes, hello. Fred Durbus, Stanford. Very nice study. Can appreciate the technical advantages of the protons and appreciate the detailed follow-up. I was wondering if you measured patient-reported outcomes just to see how they could see any differences between the two different treatment approaches. Thank you.
Yeah, thanks so much for your question. We did measure patient-reported outcomes, and that data is still under analysis right now, but we hope to be able to report that data sometime this year.
I wonder if you could comment on how long you plan to follow them. There's always a conversation that comes up with protons for breast about end-of-range biology, and will you be following them long-term?
Yeah, thanks so much, Dr. Woodward. So for the planned follow-up in this study is 5 years, but all patients were treated at Mayo Clinic as part of a prospective registry, and so we will be able to look at later time points as well to address some of those important questions.
Do you have other online?
Yeah, there are a couple more online questions. What is the cost of a course of proton beam radiation versus hypofractionated EBRT?
Thank you. That's a complicated question. At our institution, there's a price parity for a fraction of IMRT with proton therapy, meaning that a 15-fraction course of PMRT at Mayo Clinic is the same, for proton therapy is the same as the cost of IMRT. That said, thinking more globally, as I mentioned, the capital investment required to create this equipment to accelerate protons is clearly more expensive, and so there's a lot of important research that needs to be done to better determine which patients are most likely to benefit from proton therapy in the years ahead.
And I believe there's one more in person from microphone 2.
Yeah, John Benson, Cambridge, UK. Thank you very much for a very clear presentation. You mentioned that there was a significantly increased rate of complications for patients having immediate breast reconstruction. And I wondered if you could comment on the type of reconstruction, and in particular whether there were pre-pectoral implant-based cases.
Thank you. It's a great question. I can tell you that the majority of patients underwent pre-pectoral reconstruction in our study population. I do not have data yet on exploratory analyses evaluating whether there's a difference in complication rates between the patients that had pre-pectoral reconstruction and a small number that underwent subpectoral.
Yeah, I think longer follow-up will be really important for rates of capsular contracture.
Thank you.
Thank you, Dr. Mutter. And I would just draw everyone's attention to the educational session this afternoon. For anyone interested in understanding more about advanced technology and radiotherapy, it'll be directed to the medical oncologist and the patients so that you can help to understand how to be involved in those decisions. And thank you so much for that excellent presentation.